Okay. So good afternoon, everyone, and a very warm welcome to all of you joining us from different regions, contexts. My name is Yasin Duman. I'm a research specialist at the Red Crescent Movement, Mental Health and Psychosocial Support, and it's my pleasure to moderate today's webinar. This session is hosted by the Research Network, and I'm here with my colleague Julia from Swiss Red Cross, and we also have Sarah Davidson, Dr. Sarah Davidson, as the coordinator of the Research Network, but I think she's unable to join us today. And we are delighted to have such a diverse audience with us for this important discussion on self-harm and suicide prevention in humanitarian and fragile contexts. Today's webinar focuses on the findings of a systematic scoping review that synthesizes the global evidence base on suicide and self-harm prevention interventions implemented across humanitarian settings. As many of you know, humanitarian crisis, whether driven by conflict, natural disasters, forced displacement, or public health emergencies like COVID, can significantly heighten risks related to suicide and self-harm. Yet, despite this risk, the evidence guiding prevention efforts in this context remains sometimes limited, fragmented, and often concentrated in high-income countries. So our aim is today to explore what the current evidence tells us and where the gaps lie and how we can collectively strengthen suicide prevention efforts in humanitarian response and how research is strengthening this collective effort. And we are very fortunate to be joined by Chad Zemp, one of the co-authors of the review. You received in the email and a PhD candidate in global mental health at Trinity College Dublin. Chad brings both academic depth and practical field experience to this topic. His doctoral research, conducted in collaboration with World Vision Ireland and World Vision Somalia, focuses on the co-design, piloting, and evaluation of a faith-based mental health and psychosocial support intervention for individuals experiencing psychological distress in Somalia. So in this scoping review, the co-authors reviewed more than screened more than 6,000 records and ultimately identified 23 studies that quantitatively evaluated suicide or self-harm prevention interventions during the humanitarian crisis. Of course, Chad is going to tell us more details about this research in the presentation. But I can just add that we will allocate about 35-40, depending on the need, maybe 45 minutes maximum to Chad's presentation on the review, on the scoping review and the key findings. And then we will open the floor for discussion and questions. Please feel free to share your reflections or the questions in the chat throughout the session, and then we will come back to them when Chad finishes the presentation. So with that, it's my pleasure to hand over to our speaker. Chad, the floor is yours, please.
Awesome. But yeah, thank you, Yasin, for introducing the webinar and myself. Before we get started, I guess I'll go ahead and share my screen so that the presentation can be seen. Let me just do that real quick and make sure that it's, can everybody see this first title slide here?
Not yet.
Oh, okay. All right, let me try it. Oh, I didn't share a screen. I just did present. Yeah. So
now we can see it.
Here it is.
There we go. Okay.
Perfect.
Awesome. Well, yeah, so thank you, Yasin, for the introduction, and welcome everybody to this webinar. Thanks for joining, first off. I appreciate you guys taking the time out of your day to come and listen, and then hopefully to share your thoughts as well when we arrive at the Q&A session. Yeah, it's great to see so much interest in this topic, and hopefully you find the webinar interesting, informative, etc. So yeah, as Yasin mentioned, today we'll be talking about a paper that I helped out with. It's a systematic scoping review on self-harm and suicide prevention in humanitarian and fragile contexts. I had a team of co-authors with me who you see here on the screen, and we are from Trinity College Dublin, the Center for Global Health at Trinity College Dublin, Johns Hopkins Bloomberg School of Public Health, and the Red Cross Red Crescent Movement MHPSS hub. So before sort of diving into talking about the manuscript itself and our findings and discussing those findings, I thought it would make sense to just provide a very quick introduction to myself, particularly as it relates to the work that we do, and how I arrived at the field and the work I've done so far and what I'm currently working on. So I first started in the humanitarian field relatively recently, about 3 years ago, when I did a master's in global mental health here at Trinity College Dublin. Prior to that, I had been a teacher and worked in restaurants and other odd jobs. So I had no really super relevant experience before starting that master's. But I did the master's, I really enjoyed it. And through that master's was sort of my first introduction to research through the thesis or the dissertation that I completed for that, which was an analysis. I worked in collaboration with the National Disability Agency of Somalia to do an analysis of the mental health needs of Somalis with disabilities, what predicted those needs being certain demographic factors, as well as varying levels of functional impairment across different domains of functional impairment or disability, if you will. The barriers that they encountered to accessing care among those who identified the need for such care. Yeah, no, that was it. So that was the thesis. After I did that thesis, I was hired on here at the Center for Global Health to work on and I have some pictures here on the screen are meant to sort of guide me in this presentation. So that's why there's pictures here. The first one is Trinity College Dublin. The second is a picture of the logo for the Integrated Model for Supervision, which is the project I was hired on to support as a research assistant, which perhaps some of you are familiar with, but for those who aren't, it's a collaborative effort between the MHPSS hub and ourselves here at Trinity, at the Center for Global Health at Trinity College. It's an evidence-based resource guidebook to help humanitarian organizations strengthen their provision or their systems of supportive supervision, specifically for their mental health and psychosocial support work service or workforce, but can be also used for other sectors as well. So I was, oh yeah, thank you, Yassine, for sharing the link. Yeah, so in that link, you can find the guidebook itself as well as other resources. And I was hired to help out in its most recent phase, which is all about scaling it up to French, Arabic, and Spanish-speaking regions. Unfortunately, that phase was cut short because of the funding cuts associated with the USA dismantling. But the work still goes on in other sort of senses, which is nice. As part of that, I was also working on some other projects on the side, including this review, which we'll be talking about today. And then I have recently started my PhD here at the center just this past year, which, as Yassine mentioned, is focused on co-designing, piloting, and evaluating a faith-based mental health and psychosocial support approach or intervention for individuals in Puntland, Somalia, and also replicating those efforts, co-adapting, piloting, evaluating here in Ireland for Somali survivors of torture that have been forcibly displaced here to Ireland. These projects are being done in collaboration with World Vision Ireland, World Vision Somalia, and Sparasi, which is Ireland's National Centre for the Rehabilitation of Torture Victims. And the approach is called, this is the picture on the right, it's called Healing and Empowerment, Achieving Resilience Through Spiritual Nurture, which is why it's acronymized as HEARTS in this banner, which is from some co-design workshops that we did in Somalia this past year. Okay, so just a quick rundown of the agenda for today's meeting as it pertains to the research. So it follows a pretty standard sort of manuscript format, I suppose, starting with talking about the background and the rationale for the scoping review. So what information do we already know, the knowledge that exists and what is missing, and why we decided to do the review in the first place, the methodology for the review, the different components involved in the scoping review process, the screening, the data extraction, the synthesis, etc. The results of the review, so the number of records that we screened, the number of articles that were deemed relevant, and the characteristics of the studies and interventions represented in those studies. And then we'll move on to discussing the sort of key takeaways, key general reflections of the overall evidence base, and as well as highlighting a selection of approaches that we thought were promising, keeping in mind some feasibility factors and acceptability factors for their implementation in the majority of humanitarian contexts. Following this, we'll use that information to sort of recommend some future research directions, research and programming. And then we will end with, as you've seen, also mentioned the Q&A section. For this section, I would definitely, I would recommend, I'm happy to answer any questions that I can about the paper itself and the process and the results, etc. But I would also certainly welcome anybody to share any thoughts they have based on their experience, their knowledge on what we recommend or what we found to facilitate a bit more of a discussion. Because I have experience as it relates to this particular paper, but I don't have much experience as it relates to performing suicide prevention efforts or designing those efforts in humanitarian contexts. I would definitely recommend those that do have that experience to provide some insights if they would like to. Okay, so starting with the background. So what do we know and why did we do the scoping review? So despite significant reductions in the past 3 decades or so, with globally suicide mortality rates reducing by about 1/3. There are some exceptions to this in certain countries and areas where rates have been increasing, but globally, in the past 30 years, prevalence has dropped by about 1/3. Despite this, suicide still remains a leading cause of death worldwide, with about 720,000 lives being lost to suicide each year, which equates to about 1 suicide occurring every 40 seconds and an estimated global prevalence of 9.5%. Similarly, self-harm or non-suicidal self-injury, which is a strong predictor of suicide, has a global prevalence and estimate of 17.7%. So both highly, decently prevalent sort of health concerns globally. In addition to its prevalence, self-harm, according to the Global Burden of Disease Study in 2021, accounts for about 4 million disability-adjusted life years. So a very significant sort of disability burden arising from self-harm. Now, concerning as these estimates are, they are undoubtedly underestimates of the true burden. This is due to a number of factors, the first of which is that there still remains significant stigma and taboo around suicide and around self-harm in many countries and cultures around the world, meaning that people often underreport or don't report thoughts or behaviors of suicide and self-harm. This includes suicide being illegal as of 2026 in 25 countries and 27 further countries where the legal status of suicide is unclear. In addition to this, there is a lack of strong, robust suicide monitoring and surveillance system where data is actually captured and stored to allow for more accurate estimates to be established. Now, beyond the impact that suicide can have on the individual, suicide and self-harm, thoughts or behaviors can have on the individual who obviously dies by suicide or has those thoughts or self-harm behaviors. The effect of these can also extend to a wider sort of network, if you will. For instance, friends, family members, and other community members of those who do die by suicide or engage in self-harm behaviors can experience things like prolonged grief, guilt, shame, despair, and can even have developed their own mental health conditions as a result of somebody they know dying by suicide or engaging in self-harm behaviors. A recent seminar on suicide and self-harm, for instance, details that for every death by suicide, between 60 and 135 individuals are affected. So quite a wide-reaching impact of this. So for these reasons, both at the impact at the individual level and the wider impact that both suicide and self-harm can have, they are both deservedly pressing concerns within global mental health programming, particularly in low and middle income country contexts where the majority, around 75% of suicides occur. Now, as Yassine said, we know that experiencing a humanitarian crisis, most of which occur in low and middle income countries, can elevate the risk for both suicide and self-harm. This is for a number of interconnected, interacting factors. For instance, experiencing a humanitarian crisis can disrupt access to basic necessities such as food, water, safe shelter, etc. And it can also disrupt existing health systems and existing social support networks that exist to provide informal or formal mental health or psychosocial support to affected individuals. Experiencing a humanitarian crisis such as an armed conflict or a natural or climate change related disaster can lead to forced displacement, which can also contribute to, can be a risk factor for suicide and self-harm. Additionally, experiencing potentially traumatic events that come with being affected by a humanitarian crisis can also contribute to the development of mental health conditions that are known to be risk factors for suicide, such as depression, PTSD, etc. Despite this, there still remains a lack of accessible, acceptable, and effective suicide prevention care in humanitarian settings, which is in part related to the inability of governments to promote suicide prevention efforts within their countries that are affected by humanitarian crises, which again could tie into the fact that suicide still remains illegal in many countries around the world. And then finally, and of most relevance to our scoping review, is the fact that humanitarian emergencies, particularly those occurring in low and middle income countries, can exacerbate difficulties that come from minimal trained mental health personnel, whether they be professionals or non-professionals, as well as the current absence of operational and practical tools and guidance for these individuals who deliver services to identify and effectively assist individuals at high risk or who have already had engaged in self-harm or suicidal behaviors. That being said, we know that both self-harm and suicide are preventable through evidence-based interventions. And indeed, preventing self-harm can itself serve as a preventative effort for suicide. Within humanitarian context specifically, there's a handful of different strategies that do exist. These range from guidance documents, such as the interagency standing committees addressing suicide in humanitarian settings, which is more of a higher level guidance note, offering sort of important information on the considerations that should be taken into account when designing and implementing suicide or self-harm prevention efforts in humanitarian settings. And it emphasizes a multi-sectoral, multi-level, collaborative approach to engaging in these efforts. Other examples include practitioner training programs such as MHGAP, which trains non-specialist healthcare workers to provide mental health services, including those of a suicide preventative nature. However, this guidance is not suicide specific. It contains a section on this, but it's not solely designed for this purpose. Other examples are community level initiatives, such as campaigns to raise awareness around mental health and suicide in specific, and to foster help seeking among affected communities and individuals, again, trying to sort of overcome the stigma and taboo that is so heavily associated with suicide and self-harm. And then finally, as we will discuss, or as we found through our review, are interventions delivered at the individual level to prevent suicide or self-harm among high-risk or non-high-risk individuals. However, as Yassine mentioned, these interventions that exist remain few, fragmented, which is part of the reason why we decided to conduct this evidence synthesis. Oh, sorry, I had to bring my map. There we go. Now, it's worth mentioning that our review is not the first evidence synthesis to be conducted to identify effective suicide prevention efforts in humanitarian settings. To our knowledge, there were two previous reviews, as you can see here on the screen in the top box, one that was conducted by Harose et al. In 2020, and the other conducted by Rifles et al. In 2024. So both relatively recent. Both of these reviews, while serving to identify effective interventions for further research and programming, also had important gaps that we wanted to address through our review. For example, the review conducted in 2020 only focused on populations that had experienced forced displacement, finding a total of 6 interventions that had been implemented among these populations to address suicide or self-harm. The review conducted by Rifles and his colleagues expanded the scope, focusing on public health emergencies, natural disasters, forced displacement, or populations affected by those types of humanitarian crises, but they excluded armed conflicts, which, as we know, is quite a common sort of kind humanitarian emergency, and also excluded gray literature, such as reports from NGOs or governments or otherwise, in which important information and indeed results could potentially be found. So with this in mind, we wanted to identify and synthesize the evidence from records, both academic and gray, academic literature and gray literature, that explored suicide and self-harm prevention interventions across all types of humanitarian emergencies. So natural or climate change related disasters, armed conflicts, public health emergencies such as COVID or Ebola, populations that have experienced forced displacement, fragile states, etc. Specifically, we had the following research question. Which suicide and self-harm prevention strategies have been implemented and quantitatively evaluated in all types of humanitarian crises worldwide, and what is currently known about their effectiveness? Now here, I'd like to mention that this scoping review was the first step in what was envisioned to be a much larger project. So the overall project was focused on conducting the scoping review as a first step, using the results from this to feed into interviews conducted with suicide prevention practitioners, academics, other sort of experts in humanitarian crises to create this operational practical guidance for service providers in these contexts, which is currently lacking. Unfortunately, this project also sort of fell victim to the funding cuts associated with the USAID debacle, and we had to put it on pause. But we will come back to that a bit later at the end of the presentation and revisit the current progress and what we're doing next in relation to that. Okay, so that is the background and the rationale. So again, to sort of synthesize all the evidence across all types of humanitarian contexts related to suicide prevention or quantitatively effective, demonstrated to be quantitatively effective interventions for suicide or self-harm prevention in humanitarian contexts. So now just moving on to the methodology. How exactly do we do this? So for anybody on the call who is not too familiar with scoping reviews or systematic reviews, I can just very quickly introduce just in general what they are. So we conducted a scoping review, which is essentially a mapping exercise of the existing literature in relation to a particular topic or research question. So by doing this mapping exercise, you identify what exists and what doesn't exist. What are the gaps? So in doing this, after sort of developing the research question, one of the first steps is to develop a search strategy. So to come up with the terms or the truncated version of terms that you will feed into databases of literature to try and identify potentially relevant records. So this is one of the first steps that we undertook. We met with a subject librarian here at Trinity, Greg Sheath, who is an expert in all things scoping reviews and systematic reviews, to sort of develop this search string of all of the search terms that we wanted to use. And we ended up focusing the search on three different sort of topics or areas: suicide and self-harm, humanitarian and fragile contexts, and intervention effectiveness. And I'll show the exact search string we used here in a second, so you can get an idea of the breadth of it and to see some of the terms that we used. So using this search strategy, this is the process we use for the academic literature. So for peer-reviewed literature or dissertations and theses, PhD dissertations and theses. So we use this search term, we inputted it into 6 databases. Those 6 databases auto-identified potentially relevant records where any of these terms in the search string were mentioned within the manuscript, and then uploaded them automatically into a platform called Covidence, which is a platform that's used for review processes. And then in the screening process, basically in the screening process, you start by screening the title and abstracts of every populated article to see if they seem relevant. If they do seem relevant, then you pass them on to full text screening, where you read the entire article to determine if it should be included for data extraction and for synthesis in your review. And this is done using some sort of determined inclusion criteria to identify what is relevant, what isn't relevant, which I'll also touch on here in just a second. So all records that were populated in the academic search at both the title and abstract and the full text stage were screened by 2 authors. This means that it wasn't just one person deciding what was relevant or what wasn't relevant. 2 people screened everything and then met if there were any discrepancies or disagreement to talk through those disagreements together to determine if what should be included and what shouldn't be included. For the gray literature, the process was a little bit different. So gray literature involved one of the authors manually searching the website for 18 different organizations or gray literature databases using a much simpler sort of search strategy, which often was just typing in suicide prevention into the search bar of the homepage of the publications page. And then from that process, that same author by themselves did the title and abstract screening of records that were identified. And then those that they deemed to be relevant for full text screening were then screened by two authors. So any gray literature records that were included in the review were also screened by two authors. So here, just real quick, this is quite intense perhaps, but this is just our exact search string for the academic literature. So here we have our three different categories. The first one is the suicide or self-harm category, which contains all the terms, or again, shortened terms that we tried to look for in the search across any relevant articles. The second block is the terms that we use for humanitarian or fragile contexts. And the third block is the terms that were used for interventions and their effectiveness. Again, the studies had to go into the quantitative effectiveness of the intervention, not just describe the intervention itself, which is why we sort of combined those effectiveness terms with the interventions. And then in terms of the inclusion criteria, so these are the criteria that we predefined prior to beginning the screening process. This is what we use to help us identify at both title and abstract and full text screening, what was relevant, what wasn't relevant. So for the population or context, any study that involved human populations affected by humanitarian emergencies or crises was relevant.
Sorry,
no, that's
Chad.
okay, no worries.
I
No, it's
just
okay.
I just muted two colleagues. Apologies,
No, no,
colleagues. I needed
no.
to mute you.
Yeah, that's okay. That happens. No worries. So for the population or context, for this part of the inclusion criteria, the participants had to be human participants affected by a humanitarian emergency. The interventions had to be interventions with an aim of reducing suicide or self-harm related outcomes with some form of quantitative evaluation of effectiveness. So if a study only involved qualitative investigation, it was not included. The outcome had to be self-harm or suicide-related outcomes, like specifically self-harm or suicide-related, so thoughts of self-harm or suicidal ideation, or suicide attempts, death by suicide, etc. So outcomes that are related but not directly related, such as depression, PTSD, were not included. And the study design, as I mentioned, had to be quantitative or have a quantitative component. So mixed method studies that had both quantitative and qualitative were included. And then the article type would be empirical peer-reviewed literature, dissertations or theses, or gray literature, which again is reports from NGOs or governments or multilateral organizations, etc. So when we got to sort of after the screening stage, when we found the articles that we thought were relevant, that we decided based on those inclusion criteria were relevant for inclusion in our review, then you get to the data extraction, where you look for the pertinent information in the article to extract from the article to include in the manuscript or in the review. So the data that we extracted sort of spanned these four categories. So the first was study characteristics. This included things like the location where the study occurred, the humanitarian context in which the intervention was implemented. So was it an armed conflict? Was it a natural or climate change related disaster? Was it a population that had experienced forced displacement, etc.? The study design, was it a randomized controlled trial? Was it quasi-experimental, etc.? The population, the participants, so who exactly were the participants, their age range, other sort of important characteristics. And then we extracted data on intervention details. So this was, of course, the content of the intervention, the modality of the intervention. Was it delivered in person? Was it delivered remotely via online platforms or telephones or otherwise? Who provided the intervention? Was it something that was provided by a mental health specialist? Something that was provided by non-specialists who had been trained to provide it, or perhaps self-administered? The format of the intervention, so individual or group-based, the duration of the intervention, and then any training that was associated with the intervention. What was the content of that training and who provided that training, where available and applicable. We also extracted data on the outcomes of interest. So again, what were the exact suicide or self-harm related outcomes, and how were they measured, whether measured through validated measurement tools or otherwise. And then finally, the effectiveness of the intervention. How effective was that intervention in improving these suicide or self-harm related outcomes? And again, this is all quantitative effectiveness. It's not on the slide here, but we also did a quality assessment as part of the process. So we used a framework, a quality assessment tool, to assess the methodological rigor of each of our included studies. And the results of that we included within sort of our synthesis and our sort of prioritization or highlighting of certain interventions. So for the results. So using that search string that I showed you a few slides ago for the academic literature across 6 relevant academic databases, as you've seen shared at the start, a total of 6,209 unique records were screened at the title or abstract stage. Again, this was done by each record was screened by 2 reviewers, with those reviewers meeting together to discuss any disagreements or discrepancies if needed. From those 6,209 records screened at title and abstract, 104 records were deemed relevant for full text screening based on the content in the title and abstract, which followed the same process. 2 authors each screened each of those 104 records at the full text stage. And then from those 104, we deemed 23 of them to be completely relevant, i.e. meeting all of our inclusion criteria for data extraction and synthesis in the review. From the gray literature, which again followed a bit of a different process, the author who did the title abstract screening for the gray literature found 712 records that they thought were relevant based on the title and abstract of those records. 29 of those they thought deserved to be passed on to the full text stage. And then those 29 records were each screened by 2 authors, but 0 of those gray literature records were included for data extraction. I think primarily because a lot of gray literature describes interventions like in the form of case studies or otherwise, but doesn't provide much information on the sort of aggregate results of the quantitative effectiveness of that intervention, which is true for most of our excluded articles. But the vast majority of articles that were excluded on the basis of not having the correct study design. So not doing a quantitative evaluation of effectiveness. So this led to a total of 23 unique records being included in our review for synthesis. And of those 23 records demonstrating or reflecting 23 interventions, although there was one intervention that was studied by 4 studies, so 19 different interventions. 15 of those studies demonstrated statistically significant positive effects of the intervention on suicide and or self-harm related outcomes of interest. Okay, so before getting to the interventions, sort of giving an overview of their content and delivery, et cetera, as well as highlighting the approaches that we thought were promising, I just want to give a quick introduction or overview of the characteristics of the studies that evaluated those interventions. So when we did the search, I forgot to mention, but we did the search in November 2024. So anything that has been published since then will not be reflected in these results, because that is when we did the search. And we did not apply any language or date restrictions to the search. So any article published in any language or at any time was populated into the screening process. That being said, all the studies of those 23 studies that were included in our review, all of them were published in English and were published between 2003 and 2024, with the vast majority being published within the past 6 years, since 2020. Most of the included studies used a quasi-experimental design as their sort of way to evaluate the intervention, with most of these designs being a sort of pre-post study design without any control group. So just one group of participants receiving the intervention and seeing how changes in suicide self-harm outcomes changed from before to after participating in the intervention. And then the second most common study design were randomized controlled trials, which were used by 6 of the 23 studies. In terms of the participants in the studies, the majority enrolled adult participants. 14 of the 23 studies focused on adults, and 8 studies focused on children, adolescents, and or young adults. Some more sort of particular demographics for the participants were, there was one study that focused on former child soldiers in northern Uganda. A couple of different studies focused on internally displaced persons. One study with veterans, United States veterans with COVID-19 being the humanitarian context. Some studies focused on bereaved individuals who had recently lost a loved one due to a tsunami. And then students as well were represented in some of the studies. In terms of the study location, most of the studies, again, 14 studies or 61%, occurred in high-income countries. These included the United States. The United States was the most prevalent country, if you will. The United States, Canada, Australia, South Korea, the United Kingdom, and Italy. Of the remaining studies, locations included Mexico, Malawi, India, Uganda, Nepal, and Iraqi Kurdistan. Finally, as a humanitarian context of interest, most studies were evaluated interventions that were implemented during COVID-19. This sort of, there was a large overlap between those implemented in high-income countries and those implemented evaluating COVID-19. The second most common humanitarian crisis, with only 3 studies evaluating an intervention in this context, were natural or climate change-related disasters. These were done in Canada, Nepal, and India. 2 studies looked at sort of internally displaced person camps as the context of interest, being in Uganda with the former child soldiers, and Iraqi Kurdistan with female survivors of an ISIS attack. And then refugee camps were the context for one study, Sri Lankan refugees in India. And the final study was done using publicly accessible data. So from all the individuals, I think, maybe not all, but a lot of people residing in Northern Ireland during the armed conflict there, which lasted about 30 years. Okay, so when we analyzed the interventions themselves, we sort of went back and forth between how to categorize the interventions to be of most use for programmers, practitioners, etc. And we decided to categorize them based on the approach that they took in sort of trying to prevent suicide or self-harm. So the most common category that we sort of categorize interventions into were interventions that employed either a predominantly or entirely psychotherapeutic approach. So those would be things that provided content based on cognitive behavioral therapy or behavioral activation or dialectical behavioral therapy or other psychotherapeutic approaches to mental health support. So there were 8 interventions in this category. The majority of them were remotely delivered, I think, meaning via online or text-based, telephone-based platforms. 6 of these 8 were self-administered, so where the participant goes to the platform themselves and guides themselves through the intervention. And the remaining 2 were delivered by mental health specialists. So in this category, there were a few different interventions. There was one intervention that was studied by 4 different studies, which we'll come back to because it's one of our promising approaches. It was a CBT-based texting service where people received texts with supportive messages informed by a CBT, cognitive behavioral therapy framework. There were a couple of different online platforms that had content based on positive psychology and DBT and behavioral activation. And then there was a remote intensive outpatient program in the United States during COVID, which involved a range of psychotherapeutic approaches. The second most common sort of approach used by interventions were those that provide direct crisis intervention to individuals at high risk of suicide or self-harm. And the direct support that they provided could come in the form of either practical or therapeutic. A lot of these were focused around, or not a lot, but so they sort of varied in what they included in that approach. For example, safety planning, or the provision, befriending interventions where people are provided with frequent contact and emotional and social support, suicide risk assessments with subsequent safety planning, etc. Similar to the psychotherapeutic, most of these were delivered remotely via telephone or other online platforms. 2 were delivered in person, and most of them were delivered by trained lay individuals, as opposed to mental health specialists. The next most populous category were what we consider to have multiple therapeutic components. So this would be involving both sort of psychotherapeutic components, but also other therapeutic components of a different nature, things like sort of mindfulness practices or creative arts therapies, etc., together with CBT or DBT or behavioral activation, etc. So all 4 of these interventions in this category were delivered remotely, and 3 of them used a mental health specialist for their administration. The final category.
Chad,
Yeah.
sorry to disturb.
That's right.
Do you think you can finish in 6 minutes, maybe?
Yeah, I can.
Yeah. Okay.
Yeah, for sure.
Thank you. Thank you.
Yeah, no worries. Okay, so the final category that we were able to categorize interventions into were skills-based approaches. So interventions that try to build skills in the individual as sort of protective factors. These included sort of emotional intelligence, positive affect training, and another emotion-focused skills program. 2 of the 3 were delivered remotely, with 1 being self-administered, 1 being led by mental health specialists, and 1 being led by a trained lay individual. And then finally, there were 3 interventions that we did by I was not able to categorize, I suppose. One of which was a solely creative arts intervention. The other was the provision of video-enabled tablets to increase access to care. And then finally, the prescription of antidepressant medication as the sole intervention. Okay, so before getting into the promising approaches, there's a few sort of general reflections on the evidence base that we found in our review. The first is that, as we sort of went over, most of the interventions were developed or implemented in high-income countries in COVID-19, which might not be entirely applicable or feasible as the interventions are originally designed for the majority of humanitarian crises, which can occur in contexts of lower resources. So the fact that they were evaluated in these high-income country contexts does reflect suicide prevention research, 85% of which does occur in high-income countries. But again, there are a number of factors about low and middle income countries where most humanitarian crises occur, which would sort of necessitate consideration of how applicable these interventions are to those contexts. These include different epidemiological profiles of individuals in these countries who die by suicide and engage in behavior of self-harm. At times, weaker healthcare systems, fewer human resources, etc. The same can be said about the sort of multiple component or specialist-led interventions, which again, we sort of hypothesize that given the, at times, a limited number of human resources and a lot of contexts where humanitarian crises occur, interventions that have multiple different components and are therefore more complex and that rely on specialists for the delivery could either experience a sort of failure to launch scenario or not be easily scalable in these contexts. Okay, now, that being said, there were a few sort of interventions that we highlighted as promising. The first of these is called Text for Hope. It was evaluated by 4 different studies in our review, all of them occurring in Canada, just across different populations experiencing different crises, COVID-19 and a wildfire. So Text for Hope is an automated, self-subscribed CBT-informed texting service that was created in collaboration with the government of Alberta and Nova Scotia. Across the 4 studies that evaluated it, consistently demonstrated effectiveness in reducing prevalence and risk of suicide or self-harm. We highlighted it as promising due to the fact that within the literature, CBT-informed approaches have the strongest evidence base for suicide prevention and self-harm prevention, keeping in mind that, again, most of that literature, 85%, comes from high-income, largely Western countries. The fact that it's a self-subscribed texting service where the individual receives a text from the service highlights its simple automated delivery, which could help sort of sidestep some of the barriers associated with stigma and human resource limitations to suicide prevention. It's been highlighted to have quite good cost effectiveness, which is obviously an important consideration for original implementation and scale up. And there is an increasing use of mobile phone usage and ownership in low resource settings, including among displaced and refugee populations. Now, we recommend that if this intervention is adapted or carried forward or what have you, that possible integration of it or similar versions into mental health policy and or early warning systems that exist in a country affected by humanitarian crisis could help facilitate the timely and efficient implementation of the automated text being sent out. Another promising approach, this relates to some information that is contained within the IASC's Addressing Suicide Humanitarian Settings Guidance document, which highlights sort of skill building approaches as an important part of suicide prevention. So for this reason and for some others, we highlighted the promise of the emotional intelligence training, which is online, self-administered. Again, to the extent that remote options are feasible, this could help get around stigma and the dearth of human resources. It's also quite brief, 9 to 11 hours of administration, and it focuses on developing key emotional skills that could serve as protective factors for an individual, such as understanding your emotions, emotional regulation, and using them in adaptive ways. And emotional intelligence training or increasing emotional intelligence does have, likewise has strong evidence for suicide prevention. Now, there are some considerations when developing and designing and implementing remote interventions that should be taken into account. These include the need for community-driven design and adaptation, similar to sort of in-person interventions, the consideration and planning around barriers that are associated with existing communications and digital infrastructure in the context. Again, not all contexts will have that necessary digital infrastructure to provide remote interventions, but many do. Ensuring equitable access across affected populations, again, similar to in-person interventions, and then ethical considerations, particularly as it regards data security and things of that nature. And then here I just sort of point to a guidebook that has been developed by the UNHCR, particularly for designing and implementing digital mental health and psychosocial support interventions, not suicide specific, but just MHPSS in general, for populations in displacement, which could be useful to guide the development, adaptation, implementation of remote interventions. Now, remote interventions could be advantageous, but they do have some barriers and sort of setbacks for widespread implementation. So because of this, we wanted to highlight 2 in-person approaches that seemed promising. The first, they both involve sort of the provision of regular emotional support to individuals at high risk of suicide, and are both led by trained lay leaders, again, helping to get over that sort of the potential barrier of relying on mental health specialists. This is contact and safety planning, which involves this regular contact and emotional support in addition to safety planning with the individual. And then the other is just the regular provision of emotional support through frequent contact with somebody. And this sort of is important as a way to sort of increase the social support that people receive in humanitarian contexts as another key consideration, key component of suicide prevention, as outlined by the Interagency Standing Committee. Now, with this in mind, with all the information that I presented about the background and these promising approaches, and just all the interventions we found, there are a few different future directions for research and programming that we think would be important. The first among these is the need to just conduct more suicide prevention research in low and middle income country contexts and in humanitarian crises occurring in those contexts. This research could focus not only on interventions that are effective at preventing suicide and self-harm, but also the epidemiology, the etiology of these outcomes in these populations. Again, given the fact that only 15% of suicide prevention research occurs in low and middle income country contexts, this is not only an ethical imperative, but is also important to meet global development goals if they are going to be met. If done, this research could focus on some key areas. This includes developing a more robust suicide monitoring systems across different countries. One way to do this which could have been considered in its initial creation and development. But the IASC has quite a widely used and resourceful guide for the M&E of MHPSS in emergency settings, the monitoring and evaluation. But that resource does not have an indicator and a associated means of verification specifically for suicide or self-harm. So given its wide, extensive use, it could be worth exploring the feasibility of integrating such an indicator into that guide and the appropriate means of verification. Some other important directions could be sort of research focusing on the adaptation, replication, and evaluation of some of the interventions that we've highlighted in our review, or exploring that with those interventions, as well as looking at the beneficiary level impact of training programs such as MHGAP in their ability to reduce suicide and self-harm. So while MHGAP is also quite widely implemented, to our knowledge, so far there hasn't been any investigation into the impact that it has at the beneficiary level. Does training providers in MHGAP lead to any changes in suicide and self-harm among people that are receiving services from those trained in MHGAP? There also needs to be more sort of research done into exactly how and when to implement different approaches in a humanitarian crisis, as that guidance is also lacking. Okay, very quickly, again, given just the proliferation of studies in our review that focused on COVID-19, which likely doesn't reflect the same arrangement of risk factors as other humanitarian crises, such as armed conflicts or natural disasters, more research needs to be done in these kinds of humanitarian crises. This research should also try to focus on specific subpopulations that we know are more at risk of experiencing thoughts of suicide and self-harm and engaging in those behaviors. These include individuals in the LGBTQ population, persons with disabilities, children and adolescents, survivors of gender-based violence, and indigenous populations. So more research, ideally using participatory approaches where these individuals are meaningfully involved in the design, evaluation, implementation of these programs is needed. Finally, and reflecting a principal limitation of our study, is the need to conduct more qualitative research into suicide prevention in humanitarian contexts, particularly taking into account the experiences and perspectives of those with lived experience in these contexts of suicidal thoughts or self-harm thoughts or behaviors, to get their perspectives on the feasibility, acceptability, areas for improvement in these interventions without sort of involving them. There's significant risk that any developed intervention won't accurately and adequately reflect their needs and desires, I suppose. Yeah, so that, I think that brings to the end. If you have any questions about this, please feel free to contact me at the email you see there on the screen. If you have any questions about this or otherwise, I'll be more than happy to communicate in that way. And then real quick, the email is also here. I'll leave it here just in case. And then real quick for the Q&A, again, I welcome sort of people to share their thoughts and perspectives. I'm happy to answer any questions that I can about the paper itself, but if you have any thoughts, please feel free to share them on sort of suicide prevention in humanitarian context in general. And then as a final note, I mentioned at the beginning that the overall project had been sort of halted because of the funding cuts, but we are trying to sort of pick it up again. So the plan is that we will be conducting interviews with practitioners or academics or experts by other experience in suicide prevention in humanitarian contexts. So if you're interested in learning more about that part of the project, or perhaps interested in even participating, please, or have questions about it, because I just gave a very quick introduction, please feel free to reach out to me in regards to that as well, and we can communicate more about it. But yeah, I suppose that's it. Thank you everybody for listening. Hopefully it was interesting and yeah, but yes, thank you, and I'm looking forward to questions and discussion.